Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. On our last video, we discussed an approach to an edematous child in pediatrics. After looking at the evidence and clues that we were given, we came to an assessment of acute poststreptococcal glomerulonephritis, and that is what we're going to be looking at today. Just to recap on our case for those that haven't watched the previous video, we were given a 6-year-old boy who was referred from the clinic with a 2-day history of generalized body swelling. This was associated with passing scanty coke-colored urine, and there was a history of the boy being treated for tonsillitis 2 weeks before this presentation. Urine dipstick showed 3 pluses of blood, 1 plus protein, and BP was 152/92. That was our case. Now, when most of us think of glomerulonephritis, we always associate it with acute nephritic syndrome. Yes, acute nephritic syndrome is the most common presentation of glomerulonephritis, but it is important for us to keep in mind that there's actually a clinical spectrum. Glomerulonephritis doesn't only present as acute nephritis. It can also present as acute nephrotic syndrome, and it can also present as a rapidly progressive glomerulonephritis. Being able to differentiate between acute nephritic syndrome and acute nephrotic syndrome is very crucial, as these two have a totally different pathophysiology and therefore they are managed totally differently. Even though they both present with generalized body edema, but the pathophysiology of that underlying problem is totally different for the both of them. Now let's look at the triad for acute nephritic syndrome. We did say that patients with acute nephritic syndrome, they will present with hematuria. It's usually a gross hematuria. The patient will usually describe it as a coke or tea-colored urine. They will also have azotemia. So azotemia is impaired renal function. They usually have increased urea and creatinine due to poor perfusion to the kidneys. They will also have signs of fluid overload as presented by the edema and hypertension that these patients usually have. Let's look at the etiological classification of glomerulonephritis, or the causes of glomerulonephritis. These can be divided into primary and secondary. Primary means the glomerulonephritis is caused by an underlying renal disease. Secondary means the glomerulonephritis is caused by a disease somewhere else. It's usually systemic diseases. Now, if you look at the primary causes of glomerulonephritis, I'm sure some of you have seen those causes being discussed under nephrotic syndrome. Then this will take us back to the clinical spectrum of glomerulonephritis that we've just discussed. So if glomerulonephritis can present as either nephritic syndrome or nephrotic syndrome, then it would make sense why these can then share the same primary causes. Let's look at the secondary causes. Infection being the most common cause of glomerulonephritis in children. Now, infection is divided into streptococcal and non-streptococcal causes. The streptococcal cause being the group A beta hemolytic streptococcus. Now, if you look at the non-streptococcal cause, the example is other bacteria that can cause glomerulonephritis, like your staphylococcus, your pneumococcus. You look at viruses that can cause glomerulonephritis, hepatitis viruses, your HIV viruses. You're looking at fungal causes. You're looking at parasitic causes. Those are the infective causes, with group A beta hemolytic streptococcus being the most common one. Now, the other secondary class is vasculitides, or autoimmune disease or immune disorders. Now, this is especially important, especially if you're dealing with adolescent kids. If you're dealing with an adolescent child around 12 years, 13 years, who's presenting with glomerulonephritis, it becomes important to think about this subgroup of diseases. Medications, some medications have have been associated with glomerulonephritis. Few examples are your NSAIDs, hydralazine, quinine. Now, if we look at the hereditary causes, Alport syndrome is the most commonly listed cause there. Alport syndrome is an X-linked disorder that is characterized by a triad. Triad being number 1, nephritic syndrome, 2, hearing loss, and 3, eye abnormalities. Now, after having looked at the causes of glomerulonephritis, we're going to go to the most common cause, which is acute poststreptococcal glomerulonephritis in children. Please stay with me as I take you through it. So acute poststreptococcal glomerulonephritis is the most common cause of glomerulonephritis in pediatrics. It's actually the most common cause of renal diseases in pediatrics. As we've said, it's caused by group A beta hemolytic streptococcus. It usually occurs at the age between 3 to 12 years. It's rare that you will have a child with poststrep glomerulonephritis in kids less than 2 years, and it's rare that it will present in kids that are more than 12 years. As I've said before, that in adolescents, like kids around 12 years and above, you need to be thinking about the other secondary causes of glomerulonephritis, especially your vasculitides, and SLE being number 1 on the list, especially if this is a female adolescent. So this acute poststrep glomerulonephritis is usually self-limiting. So symptoms, they usually resolve spontaneously around 3 to 6 months. So BPs will normalize, the urine color will go back to normal. The incidence has been found to have dropped drastically in developed countries. This is because of their early use of antibiotic prophylaxis, especially with kids that have pharyngitis or skin infection, because of also improved socioeconomic status in developed countries than developing countries, and also because of improved hygiene that is in these countries. Let me explain the pathophysiology of acute poststrep glomerulonephritis, and this will help you understand why these patients present the way that they do and why they have some of the investigations that they have. Now, it starts with the streptococcal infection. This infection can come from the throat or from a skin infection like impetigo. Now, this streptococcal infection expresses 2 antigens. One antigen is called nephritis-associated plasmin receptor, and the second antigen is called a streptococcal pyrogenic exotoxin B antigen. Now, after these antigens have been expressed, the immune system will respond by producing antibodies towards these antigens. Now, there's 2 literatures that have been explained here. Now, it's either these antibodies will attach to these antigens in the circulation, forming an antigen-antibody complexes, or it's either they will wait for this antigen to deposit in the glomerulus, and then these antibodies will go attach themselves on top of the antigens in the glomerulus, which is called in situ attachment. Now, after these immune complexes have been formed, let's say in the circulation, because that is the most commonly explained theory, these complexes will then go deposit themselves in the glomerular basement membrane of the kidneys. And then this deposition will then trigger an inflammatory response in the glomerular basement membrane. This is called an immune complex mediated glomerular inflammation, which will lead to a glomerular injury. And after this injury has started taking place, your complement pathway will be activated, the alternate pathway, which means your C3 will start coming in, and the C3 will also attach itself on top of these immune complexes that are on the glomerular basement membrane. This is why these patients with acute poststrep glomerulonephritis, they will have a low C3 when you're doing your bloods, because most of their C3 is sitting on top of the glomerular basement membrane. And this will further worsen the glomerular injury that these patients have. There will be more inflammation, more cytokines released, more leukocytes released, and more damage happening. Now, this will take us back to the clinical manifestations that these patients have. So because there there's this glomerular damage with its capillaries around. So the glomerulus will then leak to blood and protein, hence the hematuria and the proteinuria. Now, the degree of proteinuria depends on how extensive the damage of the glomerular basement membrane is. If it's less extensive, you will have mild proteinuria, which is the most common in post-strep glomerulonephritis. If the damage is extensive, then you can have proteinuria that is in the nephrotic ranges. And then how do these patients get edema? Now, because the glomerulus is clogged with these immune complexes and complement, now the glomerulus will be unable to filtrate. So the glomerular filtration rate will drop, which will explain why these patients will be passing scanty urines. And because the glomerular filtration has dropped significantly, these patients will start accumulating fluid because the kidneys are unable to excrete some of the fluid that they're supposed to excrete. So they start accumulating fluid, and also the kidney starts having microcirculation. So it's not being perfused nicely now because it is clogged by these immune complexes, and that will then stimulate your RAS system. If there's poor perfusion to your kidneys, your RAS system gets stimulated, which is your renin, angiotensin, aldosterone system. And what this system will do, it will cause salt and water retention, which will explain why these patients are edematous, and it will also explain why these patients have hypertension. So it is because of all these things that are happening to these patients. And it will also explain why these patients, they will have red cell casts in their urine if you send it to the lab, because of the extensive damage of that glomerular basement membrane. Then you will find red cell casts in their urine. So how do we investigate these patients? So you would make sure that you do some bloods. You can start with your FBC. From the FBC, you're not really expecting anything significant. This patient might have a normal or a slightly high white cell count. They might have a mild anemia because the hematuria that they are having is not significant to give them a severe kind of an anemia. You would want to make sure that you look at your renal function. As I've said from the pathophysiology, that because of the clogging of the glomerular basement membrane by the immune complexes, this patient will then have renal hypoperfusion, which will give them azotemia, which is an increased urea and creatinine. They might also have a mild hyponatremia and hyperkalemia. Then you would do ASOT, checking for any evidence of the streptococcal infection, but bearing in mind that ASOT is not really sensitive, especially in a patient who has had a skin infection, because it can be normal in such cases. It's mainly sensitive for a throat infection. And in those cases, you would want to do an anti-DNase, because that one is much sensitive for both skin infection and throat infection. Then these patients will have a low C3, just like I have mentioned in the pathophysiology, because the C3 will go and sit on top of the complexes, and therefore it will be depleted in the circulation. And these patients, they will have that low C3. You would want to make sure that you send some urine for red cell casts. As I've said, because of the damage of the glomerular basement membrane, they will be seeping through of red blood cells in the urine. Imaging is not really needed in this patient, but you would want to do a chest x-ray, especially if your patient clinically is fluid overloaded with shortness of breath. So you would want to do your x-ray just to make sure there is no pulmonary edema. There's no really role of an ultrasound in this patient, as it will be mainly normal or slightly have increased kidneys due to the inflammation that is going on with these patients. So a question that you might be asking yourself is that, is there any role of biopsy in patients with post-strep glomerulonephritis? And the answer is there is really no role for biopsy in post-strep glomerulonephritis. The only reason why you would want to do a biopsy is when the patient is not meeting the criteria or the clinical features of the post-strep glomerulonephritis that we have just discussed. Few examples that would make you want to do a biopsy is when the patient is having a rapidly progressive renal impairment, or when the patient is having a normal C3. As we have discussed that in post-strep glomerulonephritis, we're expecting the C3 to be low. Now, in these patients, you might be suspecting other causes, other secondary or primary causes of nephritis that we've just discussed, especially some of your vasculitides. They will give you a normal C3. Or you would want to do a biopsy when this patient is having an anuric renal failure, or if there is no latent phase between streptococcal infection and glomerulonephritis. I don't know if I have mentioned this, but there is usually a period of 1 to 2 weeks before glomerulonephritis after the streptococcal infection. So if there is no latent period, if that 1 to 2 weeks period is not there, then you might want to look for other causes, especially your primary causes of post-strep glomerulonephritis. So the complications of acute post-strep glomerulonephritis are usually due to the hypervolemia that these patients have. They can have pulmonary edema, they can have congestive cardiac failure, they can even have a severe hypertensive encephalopathy, which may even be evident through imaging as a posterior reversible encephalopathy syndrome. How do we then manage these patients? So the first thing is to make sure that you do general measures. What are those? You make sure these patients are well rested. As you know that an active child, they can have slightly high blood pressures because they are not well rested. So you need to make sure that the high BPs are not affected by the child ambulating. Rest the child, monitor your renal function and monitor your urine output. As we have mentioned, what can happen to those. The second thing you want to make sure you do is to fluid and salt restrict these patients. As we have said that one of the causes of the fluid overload in these patients is salt and water retention. So you want to make sure that they don't take that externally now with their diet and all that, because it can worsen the edema and hypertension. The third step is to diurese the patients. So we've said that the cause of the swelling and hypertension in these patients, it's mainly fluid overload or salt and water retention. So you do want to make sure you diurese these patients effectively, especially before adding the second antihypertensive. You have to make sure they are well diuresed. The diuretics that we usually use furosemide, which is a loop diuretic, because it's more effective than your thiazides. The efficacy of your thiazides, it's affected by the decreased glomerular filtration rate that these patients are having. So they are not very effective as opposed to your Lasix. So that's why we use the loop diuretics as opposed to your thiazides. Antihypertensive. Again, when you're thinking of adding a second agent after you've diuresed your patient, if you're thinking of adding your second agent, you still need to think about your pathophysiology. What has gone wrong? What are you trying to correct? We've said that other than fluid overload, your RAS system has been activated. So you need to make sure the second agent that you're going to be adding, it's something that will target that RAS system being activated. Things like your AC inhibitors like enalapril. You can also use things like calcium channel blockers like amlodipine. The next step is antibiotics. Now, giving antibiotics, you're not really treating an acute infection, because as we have said, there's a latent period of about 2 weeks before these patients get glomerulonephritis. So they come usually 2 weeks later. But what you're trying to do with the antibiotics is to eliminate any lingering streptococcal infections that could cause recurrence of the infection. And the antibiotic of choice is usually penicillin or amoxicillin. Those are usually our first line. In patients that are allergic to those, then you can use alternatives like your cephalosporins or your microlides. So that is how we usually manage these patients. The important thing is taking them out of that fluid overload stage, and diuretics play a huge role. Make sure you optimize your diuretics before you introduce your second antihypertensives in treating the hypertension in these patients. Now, I've been saying differentiating between nephritic syndrome and nephrotic syndrome is very important, especially when it comes to management. Now that you know the management of nephritic syndrome, please make sure you watch the next video as I'm taking through your nephrotic syndrome in pediatrics.